It's a new era for the understanding of the causes of back pain and patients' response to care. It was initially assumed that if the patient's specific pain generator could be identified, specific therapy, whether that be surgical or conservative, could be directed at that entity. But back pain is more enigmatic than that. A specific diagnosis and effective therapy are often elusive. This is due in part to complex neurological wiring and an overlap with central mechanisms associated with chronic pain. Only 10 to 20% of low back pain cases are specific, meaning due to fracture, infection, disc herniation, or tumor. The remaining 80 to 90% of low back pain cases are nonspecific. The difficulty is that for nonspecific causes, the effects on local tissue are often transmitted to other tissues not directly involved by the initiating cause. There have been many pain-generating tissues identified. However, the complex nature of the neurological wiring makes the pinpointing of a single structure difficult if not impossible, due not only to overlap of innervation, but because there are no distinct clinical indicators for each structure per se. An early theory, still used as an explanation by some doctors to their patients, is the pinched nerve concept. It resonates with chiropractors because of the success of manipulation for spinal pain, sometimes immediate. This was a reasonable and attractive idea due to the fact that the intervertebral foramina seemed a risky area for nerve roots, and by removing pressure from small disarticulations or fixations of the vertebra, immediate relief of pain could be obtained. Surgeons were in agreement that the pressure theory was clearly the problem, but that removal of offending structures corrected that problem. Then it became apparent that small degrees of disarticulation by millimeters was likely not enough to cause direct impingement given the size and accommodation of the IVF. Also, bulging discs were present in a significant minority of seniors with no resulting pain, and that more importantly, disc herniations that appeared to cause acute low back pain and radiation were still present as the patient's pain improved. Certainly another confusion was that with nerve root pressure, and here we're really talking about a spinal nerve, not a nerve root, one would expect clinically to have effects related to the mixed function of that spinal nerve, including weaknesses of innervated muscle, denervation of skin, and a decreased reflex. These findings, though, are inconsistent. A significant misunderstanding of the neurology of back pain was that pain that radiated was assumed to be radicular, meaning from a spinal nerve, aka nerve root. Yet often no such disc pressure on nerves was seen on imaging, even with disc bulging. Clearly, there were other causes of pain other than simple mechanical pressure, and there were other sources of pain, even radiating pain, other than radicular. Let's take this opportunity to review the neurological wiring of spinal structures and then review some recent studies to see why this is so complex and see why the clinical presentations and results from care are so varied. Remember that the dorsal root or sensory nerve root and the ventral root or motor nerve root join together to form a spinal nerve. This mixed nerve, motor and sensory combined, splits into mainly two main branches, dorsal and ventral rami. And then there is the related sinuvertable nerve and rami communicans forming the sympathetic contribution. More on these mainly non-somatic pathways later. The dorsal ramus then splits into the medial and lateral branch. The medial branch is important due to its innervation of deep muscles and ligaments, the facet joints, and the periosteum of the posterior arch. The lateral branch innervates the erector spinae group of muscles and the skin. The ventral or anterior ramus contributes to the lumbar plexus, innervating the lower extremity, and the psoas, quadratus lumborum, and the intertransversarii muscles. Now, let's review specifically what is now known about the disc and other deep structures. This review by Edgar in the Journal of Bone and Joint Surgery is a wonderful synopsis that follows the history of discovery. Initially, all that was known was through dissection and then crude staining techniques that were nonspecific to any particular nerve type. Then specific staining approaches allowed, in essence, the color coding of different fiber types such as nociceptive fibers, sympathetic fibers, and specifically postganglionic vasomotor fibers. Coupled with microscopy, more detail became evident. Most of these studies were conducted on rats, which have similar neurology to humans. The key neuroelement was the sinuvertable nerve. Let's look at that first. The recurrent meningeal or sinuvertable nerve, also called the recurrent nerve of Luschka, is thought to primarily branch from the spinal nerve off the ventral ramus and re-enter the intervertebral foramina to innervate the ligaments, dura, blood vessels, intervertebral disc, facet joints, and periosteum of the vertebra. The rami communicans contains autonomic nerves that serve visceral functions, carrying visceral motor and sensory information to and from visceral organs, including blood vessels. Recall that there is a gray and white rami. These on-ramps and off-ramps respectively allow communication at the same level or at distant levels. The white rami represents pathways for exiting nerves from the paravertebral or sympathetic chain ganglion limited to T1 through L2, whereas the gray represents the pathway to the chain prior to synapse from all other areas. This is really important in our understanding of what is termed non-segmental innervation of the lumbar spine, especially the lower lumbar spine innervation to deep structures. Even before sophisticated staining techniques, it could be seen that the sinuvertable nerve split into a superficial and deep network of nerves around the posterior longitudinal ligament. The deep network had levels that could be traced to the same disc level, DRG. The supply area for the deep network was primarily the intervertebral part of the PLL and the posterior annulus, while the vast majority of fibers, estimated at 90% of fibers, were purely sympathetic to all other structures. The pattern of this innervation was interesting. The predominant sympathetic innervation was non-segmental, leaving a hole for the sensory innervation from L3 through L5. This means that discogenic pain is sympathetic pain, mediated by the sinuvertable nerves and through the rami communicans reaches the L2 spinal ganglion, but not the dorsal root ganglions of L3 through L5. Here's a schematic summary. We can see that the sinuvertable nerve and the gray rami communicans are key to understanding innervation not only of the disc, but other deeper structures. Most of the innervation is sympathetic, with some innervation to posterior structures that can include mixed innervation from the combination of the sinuvertable nerve and rami communicans. Discogenic pain can arise from the disc itself or from pressure on surrounding structures without any impact on nerve roots. The first structures affected are the posterior longitudinal ligament and anterior dura. The diffuse ache is typical of visceral pain mediated by visceral afferents of the sympathetic nervous system. When pain radiates, it's not radicular, but referred pain from the PLL or anterior dura. A side note, a new procedure you'll be hearing about for chronic low back pain is basovertebral ablation therapy. This is a fluoroscopic technique to destroy the branch of the sinuvertebral nerve that supplies the vertebral body. It's now being tested in randomized controlled trials. There's been a considerable amount of research performed on the spine of rats whose nervous systems are surprisingly similar to humans. The following studies we'll discuss used a double staining method to follow nerve fibers that dichotomize, meaning sensory nerves that have axons that project to two different places, not just one. By injecting a neurotracer in one structure and a different one in another structure, the sensory neurons of the dorsal root ganglion could be examined to see which neurons took up both labeling substances, meaning they had fibers going to both structures. This study by Sumeda et al. Demonstrated that there were dorsal root ganglion neurons that had axons that project to both the facet joint and the sciatic nerve. Let me repeat, facet joint connections to the sciatic nerve. If found to be true in humans, this certainly could explain some of the radiation that responds dramatically to manipulation, where no evidence of nerve root pressure is evident. Here is another by Wakai et al. Demonstrating dichotomizing axons projecting to both the facet joint and low back muscles, specifically the multifidi. And yet another by Unamura et al. Demonstrating the same dichotomizing of sensory nerves to the lumbar multifidus muscles and intervertebral discs, facet joints, and SI joints. They further determined the percentage of axons projecting to the multifidus from each of these structures. 9.5% of all dorsal root ganglion neurons innervating the L5-L6 intervertebral disc in the rat had other axons that extended to the multifidus muscles, and 20% of the dorsal root ganglion neurons innervating the SI joint had axons that also extended to the multifidus muscles. And approximately 25.5% of all dorsal root ganglion neurons innervating the L5-L6 facet joint had axons that also extended to the multifidus muscles. Looked at from a different perspective, they demonstrated that the vast majority of fibers do not dichotomize, but of those that do, 6.8% project to both the facet joint and multifidi, 7.1% project to both the SI joint and multifidi, and only 3.1% project to both the disc and the multifidi. Finally, let's discuss pain related to degeneration. Here is a study on that topic published in Spine in 2007, Innervation of the lumbar intervertebral disc by nerve growth factor-dependent neurons related to inflammatory pain. What is known is that ingrowth of granulation tissue in degenerating discs is vascularized with accompanying nerves. Ingrowth of these nerves in degenerated discs is deeper than originally believed, a likely source of discogenic pain having nothing to do with nerve roots or spinal nerves. In this study, it was demonstrated that neoinnervation is as deep as the inner third in 50% of degenerated discs. Proliferation of mechanoreceptors has also been shown in 50% of degenerated discs, including Golgi tendon organs type 3, which are mechanoreceptors that can be nociceptive. So let's summarize all of these newer findings. First, dorsal root ganglion neurons for the L5-L6 intervertebral disc are found from L1 to L6 multisegmentally in rat research. It's likely there is a similar pattern in humans. Discogenic pain is sympathetic pain mediated by the sinuvertable nerves, and through the rami communicans of the sympathetic chain, they reach the L2 spinal ganglion from lower levels, the ones most commonly affected by disc pathology. Low back pain may originate from the lumbar muscles directly or as referred pain from spinal tissues such as the intervertebral disc, facet joint, or SI joint. The literature suggests that referred low back muscle pain is most likely due to disorders of the posterior structures, such as facet joints and SI joints, rather than disorders of the lumbar intervertebral discs. I hope this brief review of new findings is helpful in explaining some of the clinical findings of your patients and in part explain some of the successes with those patients. What the evidence suggests is that back pain is a complex mixture of somatic and autonomic activation when acute, and this contributes to a more central processing when chronic.